Well, howdy YouTube family. It's both CRNA coming to you again with another day's topic. So today I'm actually in my new apartment. You might notice the setup looks a little bit different. This is my new office space I have over here. And I wanted to get into what it was like being a nurse, my day in the life of when I was an RN, and why I quit being an RN. Let's get into it. So a lot of you guys ask what it's like to be a nurse. Maybe you're in nursing school or you're hoping to go to nursing school and you're interested in maybe one day becoming a CRNA like I am now, which is a nurse anesthetist or nurse anesthesiologist. But before you can do all that, you have to be an ICU nurse working at the bedside. A lot of people leave the ICU as a nurse. They do it for a handful of years and then they go on to grad school or somewhere else, and they don't practice the bedside anymore. So a lot of people wonder why. Why do you leave bedside nursing? Why did you leave the ICU? Why did you leave being an RN? So today's day in the life video is going to be a typical rundown of what my everyday shift was like as an ICU nurse, and I did that for 4 years. And that maybe will relay a little bit of information to you. Maybe it'll be something that inspires you and makes you think this is exactly what you want to be. You want to be an RN, you want to go through nursing school, you want to get that license and get out there and practice. Or maybe it's just something for you to relate to if you're already a nurse and you're saying, that's exactly how my life is. Those are all the issues that I didn't want to deal with, and these are the reasons why I'm going back to grad school. So hopefully this is a little bit of information for everybody. The schedule for most RNs is going to be 3 12-hour shifts a week. And then every so often you might pick up another shift, so you might work 4 12s, some people might work 5 12-hour shifts a week, but the only obligation that most places have is 3 12s. And usually you have to work every other rotating weekend. It's very hard to find a position, especially in the hospital, in the ICU, where you don't have to work every other weekend. So I didn't want to work forever on a schedule where I was constantly having to work weekends. Another thing about the schedule of being an RN is you either are going to have to pick 7 a.m. to 7 p.m. that you want to work, or 7 p.m. to 7 a.m. that you want to work. It's pretty much expected you're going to do 12-hour shifts. You don't really have much choice in that. It's rare to find a hospital that does 8-hour shifts for your typical RN. And I didn't want to work 12 hours for the rest of my career with no option to do something different. And I didn't want to have the option of either I'm all day shift, 7 a.m., waking up at 5:45 in the morning, or you're all night shift where you don't go in till 7 p.m. at night and you stay all through the night to the morning. Either schedule is kind of restrictive, so I wanted something with a little more flexibility. But for the most part, my day in the life was day shift. I did day shift probably 75% of my time as a nurse. So I would wake up at 5:45 in the morning, get dressed and stuff, eat a quick breakfast, drive into the hospital. I would be expected to be on the unit getting ready to take report by 6:45 in the morning for the off-going shift. So report is where the off-going nurse, in my case it was usually night shift nurses, would give report to us on the 2 patients that we were receiving. Other nurses may receive more patients, but in the ICU you're not supposed to receive more than 1 to 2 patients. And so you would receive report on both those patients in the morning around 6:45 to 7 a.m. And this could last anywhere from 15 minutes to maybe 30 minutes if there's a lot of stuff going on with the patients and you need to do a lot of interactions, and the ongoing or off-going nurse is having to tell you a whole long story about complicated things that may have happened with the patient. It can turn into quite a long report, but 15 to 30 minutes is your average. Usually this report is going to be done at the bedside. You're either at the bedside or you're going to be probably outside the patient's room in the ICU, and that's just so that you can visualize the actual patient as they're giving you report. When they're pointing out the different drips and infusions they're on, you can actually see what's happening in the room, and also with the criticalness of the patients, it makes more sense that you're both directly laying eyes on the patient and both handing off the condition of the patient and the current status that they're in. So after report, let's say it's 7:30, 7:45, Now I'm going to dig through the chart, whether it be a computer chart or a physical chart. I'm going to dig through the chart and fill in the gaps and what they didn't have time to tell me. They're not going to give you every single detail in report. Most of the time they don't. So you're going to have to fill in the gaps on maybe some of the x-rays that have been done the previous day, or maybe progress notes that certain physician specialists have come through. Usually ICU patients may have a team of one medical team, one primary medical team, the internal medicine physicians, but then they're going to have like 4 or 5 specialist physicians or nurse practitioners who are going to be rounding on these patients and making decisions, whether it be like heme oncology. You could do pulmonologist, you could have endocrinologist, all kinds of different specialists are usually consulted with these patients. So I'll go through, I'll read their notes, see what they're doing, their progress, what their plan is, because upcoming very soon is going to be grand rounds in the morning. And if you're not at a facility that does a grand round, you're still going to have physicians who are rounding individually, who will individually be expecting you to update them and tell them on what's happened with the patient throughout the night, what the meds have been titrated with, your recommendations on what's happening. So you need to get a good idea of exactly everything that's happening with this patient, because you will be expected, when everyone else rounds in, you'll be expected to be the gatekeeper who has all the knowledge on what's happening with this person. So you have to brush up on the previous labs, you have to brush up on the previous scans and all that stuff to get a good idea. So you could spend another 30 minutes or more doing that for both patients easily, but hopefully you get quick at assimilating that data, assemble an idea of what's happening with this patient, and then it's going to be about the time for those grand rounds to be happening. Now, grand rounds is what it's called in more of a teaching academic facility, and that's when the whole team of providers will show up, usually on the unit. You'll have nutritionists involved, you'll have physical therapists involved, you have speech therapists involved, you'll have, the med students will be there, the residents will be there, the attending physicians will be there, you'll have nurse practitioners and PAs who are on these teams as well there. It'll be a whole group of people, and they will at some point expect you to present the patient from your nursing perspective and what's happened through the night and progress that's been made and all that. So you need to be ready for that. And like I said, if you're not an academic facility that does the grand rounds, they will be around those groups of people, PT, speech therapy, nutritionist, respiratory therapist. Everybody's going to be coming around doing their own personal rounds, seeing their patients and addressing things that they need to do. And they're going to be asking you about what's happening with the patient, what's going on with the tube feeds, are they having bowel movements, have they gotten up out of bed, all that kind of stuff. The respiratory therapist may ask you about, the vent settings that have happened through the night, or are you planning to wean off the vent for the day, and things like that. So you really need to have a good idea first thing in the morning, everything that's going on with these patients, because you will be bombarded through the morning with people coming to you expecting answers so that they can create treatment plans and changes in progression. So rounds are over, or maybe you've got the brunt of people coming through asking you updates and questions through the morning. Now it's time for you to give your morning meds. 9 a.m. is the time for most places that are going to have their morning meds to be passed. And ICU patients are going to have sub-Q injections that you're going to have to give, like Lovenox and blood thinners and stuff, maybe insulin, blood sugar checks, things like that. They're going to have probably most of your patients in the ICU are intubated, and they usually have an orogastric tube to their stomach for food and for medications. So you'll have to go crush up all those pills that they have. They might have 15, 20 pills that you have to crush up and liquefy, which can be time consuming. Some pills do not want to be liquefied. So that can be a whole ordeal, trying to break down some of these very hard concreted pills into a way to inject down an OG tube. Hopefully you don't clog it up, which definitely happens, and then that can delay all the rest of your morning. So you give all those medicines, and then they're almost always going to have electrolyte replacements. ICU patients intubated, restrained, sedated. It seems like every morning their potassium is low, their magnesium is low. Their electrolytes are always out of balance, so you're always having to replace. You can count on it that you will have potassium to infuse, you'll have probably some mag to give. These things take time. Potassium can take hours, especially if it's very low. You can only infuse it at a certain amount per hour, so that can take a long time. You're going to have antibiotics. These patients are either septic, or they're in respiratory failure with pneumonia, or they have some other opportunistic infection happening, so they're going to be on Zosyn and maybe vancomycin and other high-powered antibiotics that also take a long time to infuse. You'll have a whole row of antibiotics to give, you'll have your electrolytes to replace, you'll be giving stuff through the OG tube, you'll be injecting stuff into the sub-Q tissues, you may be giving IM injections. Pretty much every route that you can imagine you would administer medications to a patient as an ICU nurse, you're going to be doing it. Oh, and I forgot to mention, right after you get report and you're assimilating data on your patients, you're then going to do your morning assessments. That's going to be before rounds and before your meds. You're going to do your 8 a.m. assessments. In the ICU, you have to do a whole head-to-toe assessment every 4 hours and chart it. So at this point, you're going to be checking everything out on the patient, looking literally at everything on them from head to toe. You're going to be assessing their meds that they are infusing, their infusion bags and stuff. They're steadily decreasing as they infuse per hour, so you'll need to be hanging new bags that are maybe almost empty. You'll be checking their vasopressors, which are the medications that keep their blood pressure and heart rate up. You're going to be assessing those to make sure that the bag's not running low, or maybe their blood pressure is trending down and you need to titrate those drips up. You'll be doing the same with sedation. If you're noticing that the sedation is not working, or they're starting to become alert or fighting the ventilator or things like that, you need to be titrating up on the sedation medication. If you know the plan for that day is to try and wean the patient off the ventilator, you would be at this point titrating the sedation down and trying to get the patient more alert, and trying to work with respiratory therapy to get the ventilator settings turned down some, so it's less assist and more of them doing the work on their own, which is called more of like pressure support mode or SIMV mode. So anyway, you're going to be doing all of that stuff right around the time for it to be rounds. Now, meds are done, assessments are done. Maybe you've had a chance to chart these things. It's going to be at least 10 a.m. at this point. You're going to have family members coming in for visits. You're going to have family members calling. You're going to have the other specialists still rounding at this point. You're also going to be implementing the new plan. So after grand rounds, the treatment team will decide on what the day's plan is going to be for this patient based off what everyone said in the rounds. So they're going to have new orders put in. So now you're going to be, new orders are being put in on your patient. You're looking at the new order set saying, oh, okay, so they want this done and this done. They want a CT of the head. They want the patient to go for surgery today. They need an endoscopy done at bedside. So I need to communicate with the GI lab and see when they're going to come up and do that. And I have to maintain the sedation while they do the GI scope at the bedside. And there's going to be some treatment plans for the patients after grand rounds, and that's also going to be kind of what you need to be focusing on the rest of the day, on top of maintaining the patient and all the drips and the infusions and the phone calls and everything else. Now you need to implement all these new plans. Now, while all of this is happening, keep in mind, this is the critical care unit. You're anticipating that your patients are going to be stable and maintaining a decent, hemodynamic status, and there's no weird EKG rhythm changes or any emergencies happening. If there's emergencies happening or critical things going on with your patient in the moment, all of this gets pushed to the side, and you spend your time in the room with the patient trying to maintain their life and keep them going, and calling up the treatment team and trying to find new interventions to stabilize the patient, whether it be blood products you need to infuse or emergency dialysis to start, which is usually bedside. We call it CVVHD, and which means you have to maintain all of that. So that can all throw a monkey wrench in your whole morning's plans of all these things you need to get done. If the patient is not stable, the patient comes first. So you're going to do all those things, and everything I just listed off that takes hours of time, that's just backpiling. You'll just have to be doing that later in the afternoon, trying to catch up on everything. Or hopefully someone will jump in and help you. Sometimes, in nursing, teamwork is awesome. Sometimes you get a good team, and one of your friends who maybe finishes their workload early can come help. So say it's the afternoon time now. You're looking at other things like the nutrition needs of the patients. You're looking at afternoon labs. Is their albumin levels low? Are they renal failure? Do we need to switch the tube feeding to a renal failure type diet? If they do have to go for a CT, you're communicating with a CT, which is a head scan, a CAT scan of the head, or the body or abdomen, wherever it is that they need to CAT scan. That could be something you would be coordinating with the radiology department to figure out when they have a time slot open. If you've got an intubated, sedated, multiple drips patient, that means you have to carry all of that downstairs. You go with the patient, you hand ventilate the patient, or you have a ventilator that's a travel ventilator. You have to coordinate with respiratory therapists. It's a whole ordeal. It's a very big ordeal, and it happens very frequently that your patients in critical care will need some kind of advanced scan, and you will have to facilitate that happening. So you're going to be doing that. You're going to have family members coming through. You're going to have distressed, upset family members. Remember, it's critical care. Their family members may not be doing well. They may be declining. This may be the worst time of their lives, and they're going to be looking for you to give them some comfort and to give them some explanations. They probably missed the physicians and the nurse practitioners when they were rounding. They probably didn't get an update, or maybe they did get an update and they didn't understand what the update meant, or they couldn't think of questions during the moment when the providers were in the room, so now they're asking you. So now you're trying to explain things to families, and you're trying to be sympathetic, and you're trying to, comfort them in times that they may just need someone to hold their hand and they want to cry because their husband of 40 years is dying slowly. So those are things that are going to be popping up all throughout your morning while you're juggling everything else, and all the other phone calls that will be happening, and you'll have to stop and pause for a moment and just remember you're a human being and you're a nurse, and your patient is not your only priority. You also have family, which becomes a major part of your life as an ICU nurse. So another thing that could be happening at this point is, say your patient's not declining. Say your patient's doing very well. You extubated this morning. You really worked hard. You got them breathing on their own again. You got the sedation turned down. You got them woke up, extubated. They're doing well. They've been breathing on their own for 6 hours now. It's the afternoon, and the ER is calling and saying they've got a crashing and burning patient downstairs. Maybe it's a trauma, maybe it's a DKA patient who's got to get a whole DKA protocol and electrolyte replacements and all this fluid and all these interventions and the insulin drips and stuff, and they have to come to the ICU. They need a bed up there. So you're somewhat healthier patient who is not as critical as they were yesterday. Now it's time for you to start working on transferring them out to a step-down unit. So you need to be calling the step-down unit, giving a report, getting the patient all together, making sure all their medications are in, making sure that they're totally stable and that you're not about to ship them off to a medical floor that can't handle a patient who may not be stable yet. So you'll do that, you'll physically transfer them, and then they'll be cleaning that bed, and you'll be immediately receiving a report from the ED saying, this is all the issues with this patient, this is all the interventions they need. Prepare for us, we're coming up, and then you're going to receive a whole new patient, which requires a whole set of admission paperwork, which can take an hour, the admission paperwork on these patients and all the things you have to do, especially a new critical patient that needs stabilization. That's going to be a whole mess. DKA patients are just one example. There's many types of examples, respiratory failure, all kinds of stuff that you can deal with in the ICU that can come your way from the ER that could take up hours of your time just stabilizing. And then you'll also have your other patients still that you're still maintaining drips on, still giving medicines to, still fielding phone conversations to providers and families and stuff while you're getting this new patient in. Now this all sounds like a lot, and this is a lot. Somewhere in this time I just listed, you hopefully have peed and ate some food at some point in the last 8 or 10 hours. Maybe you haven't. There are definitely days where it became 4 p.m. and I realized I've not eaten anything since 6 a.m. when I left the house. I have peed once 7 hours ago. I've not drank any fluids. I'm totally drenched in sweat and very stressed out and extremely tense. And I still have 5 hours of work to do, and I've got 3 hours to do it in before night shift comes in. So this is about the time when 4 p.m., 5 o'clock hits and you're realizing I need to wrap up what I'm doing for the day and wrap up these, most of what I'm doing with these patients, because the oncoming night shift's coming in and I don't want to leave them with a mess. I don't want them to come in and start their shift with a whole bunch of stuff undone, patient looking terrible, maybe sitting in a bowel movement or something, tube feeds not given, all meds still not done, maybe they're not hemodynamically stable and I've not worked to stabilize them well yet. Maybe they need a second or third IV that I've not started yet. All these things are on your list that's probably popped up through the day that you need to get done before night shift comes in, on top of all your paperwork, which everything that I just mentioned you're going to physically be doing. There's like 3 pages of paperwork for every item that you have to fill out, or check boxes that you have to do. That's a huge portion of your job as a nurse, is chart. You could spend probably half of your 12-hour shift just physically typing on the computer, charting everything that you're doing, and that's required of you. So you worked your butt off, you did a good job, you got a new patient in, you admitted them, you got all the paperwork done, you got their meds in, they're mostly stable, everything is looking okay. It's 6 p.m. Night shift is going to be showing up in the next 30 to 45 minutes to receive report, and now you can catch up on the last little bit of things, try and wrap the patient up in a nice pretty bow for them so they don't come in upset at you. And Murphy's Law, especially in the ICU, is that this is the time where the patient will have something happen. They're going to, the lactulose that you gave at 9 a.m. that morning is finally going to kick in, and they're going to have explosive diarrhea all over themselves, all in their bed, down to their ankles. It's going to drip on the floor. It's going to coat their SCD hose. Somehow it's going to come upwards, and it's going to be on their abdomen and it's soaking their gown. You're going to have to do an entire bed change, get all new supplies. That's when that happens. And usually when you're wrist deep into that is when your other patient's room starts beeping or things start going off and alarming, and you're jumping back and forth between both places. And then night shift comes in and you're looking terrible. Your patient doesn't look great. They're covered in poop, half of it cleaned off, half of it not. And they're going to have their Rockstar energy drink, and they're going to walk off to the locker room and be like, you better get that under control before I get back, because they're not looking to be handed off a mess. So you're going to wrap that up as fast as you can. You're going to be stressed. You're going to try and give a quick report, while you're sweating and trying to wipe up the last bit of poop off the floor. And then that will be your night. You'll go home and you'll go to sleep so that you can go back and be there at 6:45 in the morning again and do it again. I did that for 4 years. I actually enjoyed being an ICU nurse, and being a bedside nurse, I would have never done anything other than the ICU, I don't think. If I had worked outside of the ICU as an RN, it would have been in a more corporate role or insurance or something like that. I would have gotten in outside of the direct hands-on patient care stuff. But the criticalness of the patients, how much they actually needed me, that's something I really enjoyed about being an ICU nurse. I did not, a couple times in my career, 4 years, I would float to a med-surg unit or some other type of unit that needed help, a progressive care unit, and I would try and take some patients there. And I just was not fulfilled on those days when I would try and help, because I felt like the patients didn't need me that much. Before I get long-winded here, yes, ICU nursing was rewarding, it was tiring, it was stressful. I think it was worth it. I do enjoy my years of being an ICU nurse. Would I ever be an ICU nurse again? Probably not, no. I would choose a different career path. Because I've gone on back to school. I'm a CRNA now. My perspective and where I am in life is just different. But for when I was 23, 24, 25, 26, that was awesome. That was a great career. That was a great time in my life. And I think it did help me build myself into the clinician that I am today. And it does prepare you to go on to become a CRNA, or to at least start at your baseline training to become a CRNA. I think those years of ICU nursing really enable you. And it gives you depth and a richness to your practice as an anesthesia provider that other competing anesthesia providers just don't have. And I think that's really important. All right, guys, I want to hear down below from you, if you're a nurse, what you love about being a nurse, what your your typical day in the life of being a nurse is like, and if you can relate to anything that I had to say about my time as being a nurse. If you didn't like being a nurse, write down below what you didn't like being a nurse, what caused you to dislike it, and if you're doing a different career field now, what are you into now? I always find it interesting to talk to people who were nurses and then now they do something different, because I feel like being a nurse is almost like a cult. Like you struggle so hard in nursing school and through training to get molded into this thing that is a nurse, and so to break free of that and to go somewhere else that's like totally outside of nursing is just really interesting to me. So let me know down below, and make sure to join the membership if you guys want to get into CRNA school and you're hoping to get that 26-page study guide, or you want to do personal one-on-one mentorship with me. I have like 50 of you guys in the membership now, and I really love connecting more one-on-one with you guys who are in the membership. And make sure to hit that subscribe button if you're not subscribed, and follow me over on Instagram. It's Bolt CRNA over there, and that's Bolt out.